before we go into this, we will first have the keynote address by Dr. NITIN Verma, and after that we'll go into the other topics. With no further ado, we'll just start off the session. Thank you.
Thank you. To do with structure has got nothing to do with anything else but function. Uveitic glaucoma is responsible for up to 15% of visual loss in patients with uveitis. And it's more often more an elevation of intraocular pressure rather than glaucoma. And steroids are responsible for 50% of this pressure elevation. So the other thing is, of course, this often requires surgery to fix. If you look at the frequency of elevated intraocular pressure, anterior uveitis, whether acute or chronic, is responsible for 70% of pressure elevation, and steroid therapy for 50%. The posterior uveitis often doesn't have much to do on its own. The mechanisms, quite understandably, could be related to the angle, where the angle you could get angle closure or ciliary body rotation, aqueous misdirection, or it could be involvement of the angle with trabeculitis and blockage of the trabecular meshwork, and of course a steroid response. But quite often there's a bit of this and a bit of that. So when it comes to management, control of uveitis is paramount, and then the next thing to do is to determine the cause of the glaucoma. Very often the thing that gives you the answer is gonioscopy. Very underdone, underutilized, simple investigation that one needs to remember to do. But also one needs to look at the issue of ciliary body rotation, because the treatment of that is obviously not a laser PI. Medically, the pressure is to be controlled, and quite often surgery is needed. I'm not going to dwell too much on the medical management. It's fairly straightforward, and you can understand why the one thing to avoid is pilocarpine. It's really the surgery which is the key in many cases of uveitic elevation of intraocular pressure. So the indications for surgery are uncontrolled intraocular pressure, maximal medical treatment, and very rarely increased cupping and visual field loss. But most often it's an alarming rise of intraocular pressure which is uncontrolled. What are our options? We've got trabeculectomy, we've got glaucoma drainage device surgery, and in eyes with very limited visual potential, perhaps cyclodiode. One can consider things like SLT and MIGS and non-penetrating glaucoma surgery, but certainly what needs to be avoided is ALT and phacotrabeculectomy. Standard trabeculectomy has a very high failure rate. In fact, only 30% of them would succeed at 5 years. But enhanced trabeculectomy with the use of antimetabolites is, I think, the way to go. Mitomycin C is used intraoperatively. It has longer-term effects and inhibits cell growth for more than a month, and now is the standard of care for trabeculectomy. At the Sydney Eye Hospital, we use concentrations of 0.4 milligrams per mil and apply it for 1 to 3 minutes. 5-FU is used post-surgery. It's used along with phacotrabeculectomy and also at the time of cataract surgery. So coming on to the standard mitomycin C trabeculectomy, I think I use a phonics-based flap, and really the key is to apply the sponge with mitomycin C, very often a neuropathy, for about 1 to 3 minutes in the phonics as well as on the sclera. We use a standard Kelly's punch, peripheral iridectomy, and then tenonylon for the releasable sutures for the flap, and 9-O-Vicryl for the conjunctiva. But in all this, glaucoma surgery is the easy part. The thing that decides success is the post-operative, your post-operative, what you do post-operatively. And really, that's what decides between success or failure. The post-operative management of the post-operative course is divided into 2 phases. The first 10 days or so, where we've got to modulate flow. So if you've got a flat AC, reform it. If you've got to release a suture, release it. And then after that, you go for the next 2-3 weeks, where that's where you regulate the inflammation and flow. It's important, it doesn't matter what type of releasable suture you use, it's important to release them early. And it's best to release them one by one so you can titrate what you want to do. Sometimes it's necessary to do bleb massage. But then after about day 7, the inflammatory response starts. And that's really when you go on to the next phase of controlling bleb inflammation. Now, the Mofield's bleb grading system is a great system to use so that you can sort of try and quantify what you do. And basically around the grade 2 vascularity is when you start pumping the steroid in, 6-7 times a day, and also give a little injection of 5-FU. One can give more than one injection, but when it finally comes to a point where the bleb is encapsulated, then it's best to do an early needling with 5-FU. So while there are no prospective studies, a lot of retrospective case studies show that there's a 90% success rate at 1 year. And of course, the risk factors for failure include cataract surgery and chronic grumbling granulomatous uveitis. Coming on to glaucoma drainage devices, I don't know what is the one you use here. I believe it's the Ahmed valve and the Bearwelt valve. I tend to use the Molteno valve simply because it was invented by a friend of mine, Tony Molteno from Dunedin in New Zealand. This is slightly different in that it does not have a valve. It's just a plate with a tube, and so you've got to tie the tube off after placing it, and the tube is covered with either pericardium or with sclera. We close the conjunctiva with 8-O Vicryl and actually tie the tube off for the first few weeks so that a nice capsule, a nice bleb forms around the tube, around the glaucoma drainage device plate, and so that in about 5 or 6 weeks, when the Vicryl suture pops, flow starts into a preformed space. So really you need to continue using the glaucoma medications even post-operatively. If there's any hypotony or inflammation, one needs to control that very, very well. The success rates are pretty good, 54% at 5 years. And really about a quarter of them after 5 years would require additional treatment. But the use of mitomycin C and 5-FU in this case is not really necessary. So the tube versus trab study certainly points more towards a tube than trab. And as you would see in this case study, I had a 46-year-old patient treating for a PED. Everything was going very well, and then she developed endophthalmitis. We treated the endophthalmitis. Her vision came back after vitrectomy and lens extraction. Here are some photographs of, the disaster that endophthalmitis produces with nerve swelling, macular swelling, and everything. This is what her OCT looked like. So rather than being just a macular degeneration issue, it became a uveitis following the endophthalmitis. Tried her with oral steroids, fantastic response. Then gave her an Osidex, and then, of course, the pressure just shot up and wouldn't come down. As you can see the swing of pressure here, as well as the swelling of the optic nerve. And that's really a graph showing you how erratic everything was going. But now, after a Molteno valve, her pressures have come down. And I still have to think, now I'll need to give her another steroid injection, but hopefully the valve will be able to take care of pressure rise. On the issue of MIGS or non-penetrating glaucoma surgery, it's sort of a changing area. A lot of people are talking about it. And the minimally invasive glaucoma surgery business, one can see that it acts in different ways. Of course, the CyPass is now off the market. People have tried to create algorithms that in this case you do this, in this case you do that. But I still remain completely unconvinced that this is a good idea in patients with uveitis, so I tend not to use it at all. So to close off, I think mitomycin C trabeculectomy is fine. When one needs to repeat such surgery, you might consider doing a tube. But in high-risk patients, I think a primary glaucoma drainage device is the way to go. So the take-home message is that you can do whatever surgery you want, but the post-op care is absolutely critical. Mitomycin C and 5-FU have changed things quite a bit. Tubes are being used increasingly, and again, for this thing of mention, I still don't think that MIGS and non-penetrating glaucoma surgery is a good idea in such patients. So, thank you.
Thank you, Dr. Nitin, for a wonderful presentation. So I just would like to ask you a question. So hypotony is a major issue in uveitic eyes. So how do you deal with that? What is your experience of using Ologen?
Well, I haven't used
Okay.
Origin, but I think hypotony is quite often related not only to the glaucoma surgery but also to the uveitis itself. So unfortunately, you have to be pretty hard on the uveitis, and then you run the risk of glaucoma response on the other side. So it's a minefield. And that's why I'm saying it's not the physical act of surgery that matters, it is the post-op period
Post-op
and the
management.
lifelong continuation of monitoring for these patients. I think that's the important thing. It's not just simply, oh, I've done a trab and so it's all fine. In fact, that's sometimes the start of the problem.
Thank you. Thank you, sir. We'll start off with the